Well, I think that I would like to thank the speakers and all the participants to this very interesting session. And we have a very good comprehensive review of all the problematics in the early stages. And I think that we can move to the next session, the last of our meeting. And we have two speakers, Dr. Stefan Liu and Dr. Paul Bass from Washington and Amsterdam. And we will start with Dr. Stefan Liu, addressing the problem of small cell lung cancer in the era of immunotherapy. You know that small cell lung cancer has received the same treatment for more than 30 years. And just recently, immunotherapy has bring some new opportunities to this kind of patient. So it's my pleasure to introduce Dr. Stefan Liu from the Georgetown University that will address the question of small cell lung cancer in our time. Please, Dr. Liu.
Thank you very much, Professor Crino. Very glad to be here with you to talk a bit about small cell lung cancer. I really appreciate the invitation. Here are my disclosures. As Lucio had mentioned, small cell lung cancer is an uncommon subset, not rare, about 13%, but it's really going to vary based on the smoking habits in your particular geography. It is, however, responsible for a disproportionate number of lung cancer deaths. Strongly linked to smoking, we do use the TNM staging system, but most of us have adopted the modified VA lung group staging system, splitting cancer into extensive stage with systemic therapy alone and limited stage with chemoradiation. It is a rapid clinical course. Patients will typically describe a few months of symptoms, often presenting requiring hospitalization in distress. It is a very central tumor, which is part of the reason why it presents with so many complications like obstructive pneumonia, SVC syndrome, and the like. About 2/3 at least are advanced at the time of initial diagnosis. And what we see with small cell lung cancer is a very central tumor. This was one of my patients from several years ago with a tumor that popped up very quickly, very fulminant symptoms requiring hospitalization, significant shortness of breath. Not uncommon to see scans like this for small cell lung cancer. Initially, small cell is very responsive to chemotherapy. And if you look in vitro, small cell lung cancer is responsive to at least a dozen different cytotoxic agents, really unheard of with other cancers. We can see rapid clinical improvement. If we look at the original studies of platinum etoposide, the response rate is north of 60%. Patients can have complete responses. That's not uncommon. In fact, for my patient, when we gave platinum etoposide, we did see a rapid response, generally felt better within a few weeks. The problem has never been response. And we can give other drugs that'll have even higher response rates. That's never been the issue. The problem is relapse. When we look at platinum etoposide, the median progression-free survival is only 4 months. And that starts from the time of cycle 1, day 1. So 3 months of that is just receiving chemotherapy. Most patients are progressing by the time of their first scan after chemotherapy. Survival had been trapped in that 8 to 10 month range. If we look here, the Kaplan-Meiers from platinum etoposide, the vast majority of patients are having relapse within that first year. That's basically one of the main tenets of small cell lung cancer is that it's initially responsive to chemotherapy. Patients feel better, but we expect a relapse. And upon relapse, it's a very different disease. It's refractory to most agents with minimal prospects for long-term survival with chemo alone. So if we look at the patient that I had treated, we gave chemotherapy, the tumor responded very well. And really after cycle 4, we saw rapid recurrence, platinum refractory disease, quick response, quick relapse, and unfortunately did not respond to subsequent therapy. This is what we see with small cell lung cancer. And as Lucio mentioned, this is what we've seen for 40 years, and yet we haven't really adopted our therapy. Platinum etoposide was first introduced in the 1970s, and it's been our standard since the 80s. We've been trying to do better. Dozens of randomized phase 3 trials have failed to improve survival. There are a lot of challenges with drug development in small cell. It is a smoking-related cancer, so patients often have other comorbidities. They often present very quickly, very fulminantly, and enrolling into trials can be challenging. In addition, chemotherapy, as limited as the long-term prospects are, it's very easy to give. And at the very first couple of weeks, actually very satisfying. But as a result of limited biopsies, limited trial enrollment, we have a pretty poor understanding of the biology. And we really are in the infancy of small cell lung cancer. We compare it to the advances we've made in non-small cell lung cancer. Enter immunotherapy. Here we see activity across tumor types, and we noticed that there were more responses in smoking-related cancers, presumably more mutations, which leads to more neoantigens. And we know that small cell lung cancer does have a high number of somatic mutations. And this was the basis for Empower 133. This was a randomized, double-blind, placebo-controlled global phase 3 trial for patients with extensive stage small cell lung cancer. All patients receive 4 cycles of standard carboplatin and etoposide and are randomized to receive concurrent and maintenance atezolizumab or placebo. We presented these data in September 2018. There was a modest improvement in progression-free survival with a hazard ratio of 0.77, but a significant improvement in overall survival. The hazard ratio here, 0.70, an improvement in the 1-year survival rate from 38% to 52%, and the improvement in the median from 10 to 12. And I appreciate that it's not a hazard ratio of 0.9, that we're not showing response rates or PFS numbers that we see in ALK or RET non-small cell lung cancer, but to see any improvement was a major advance for small cell lung cancer. Someone pointed out that towards 18 months, it seemed as though the curves were coming together, but we realized there's a lot of censoring towards the second half of that curve based on follow-up. In fact, Dr. Martin Reck presented these data looking at the 18-month survival rate, and we see with more follow-up, the difference in 18-month survival is the same as the difference in 12-month survival. And so that difference, that separation of those curves is persisting over time. This led to looking at the toxicity, and what we see is atezolizumab does increase PFS, it increases OS without significantly worsening toxicity. If we look at a surrogate for that delivery of chemotherapy, we see patients receive a median of 4 doses of carbo, 12 doses of etoposide, or 4 full cycles of chemotherapy. So adding atezolizumab improves outcomes without compromising our ability to complete 4 full cycles of chemotherapy. Based on safety, survival, the FDA approved platinum etoposide and atezolizumab in March 2019. EMA approved in September of that year, and it's been an NCCN Category 1 option since. We waited 4 decades to really see an improvement in survival for small cell lung cancer. We waited less than a year to see the second trial, and that was Caspian. This was initially presented by our colleague we just heard from, Dr. Luis Pazarez. This was a 3-arm open label study, frontline small cell lung cancer with a randomization to platinum etoposide alone, platinum etoposide with durvalumab, or platinum etoposide with durvalumab and tremelimumab. What we saw were strikingly similar results. When we add a PD-L1 inhibitor to a platinum etoposide backbone, we have a modest but significant improvement in survival. Here we see the hazard ratio of 0.75, and the shape of the curves really is the same. These studies reinforce each other. If one had been positive, one negative, I think we would have called the results into question. They were both positive to the same degree with Kaplan-Meier curves that almost overlap completely, really reinforcing this strategy and validating each other. The third arm in this study was a combination of durvalumab with tremelimumab, the CTLA-4 antibody. That arm was negative, not improving survival. Here we see these survival curves overlap. And while towards the end of that, we can see that the durva-tremi arm seems to catch up to where durvalumab was, but not quite. Overall, this did not add efficacy versus chemotherapy alone or versus durva with chemo. It did, however, add toxicity. If we look at immune-mediated adverse events, 36% with durva-tremi, 20% with durva alone, more treatment-related AEs leading to death, more grade 3-4 adverse events. So tremelimumab adding toxicity here without adding an improvement in survival. That did not change practice, but durvalumab did. This was approved in March of 2020 and is in the Category 1 preferred option as well for the NCCN. So now we have 2 new standards of care for the frontline treatment of extensive stage small cell lung cancer. When we look at these curves, they look very similar, splitting at about the same time, a similar degree of separation and follow-up. These are 2 very similar trials and similar results, both FDA approved. There are differences between the trials. Caspian included untreated asymptomatic brain mets, though it was a small population. PCI was allowed in both arms for Empower 133, only the control arm for Caspian. Caspian had platinum, either cisplatin or carboplatin, whereas Empower was carboplatin alone. Caspian allowed 4 to 6 cycles in the control arm. Empower was really just 4 cycles. Tesla was done about a year before Caspian, some shifting environment. But even despite all these differences, these curves look the same. And the control arms almost overlap. What that tells me is all these differences that we spent decades arguing, cisplatin or carboplatin, 4 cycles or 6 cycles, probably don't matter. Now we have something much more meaningful to talk about. Those differences are incremental, if at all, really similar outcomes for both of these studies. And when we look head to head, the efficacy outcomes, the safety outcomes are strikingly similar between the 2. When you add a PD-L1 inhibitor to platinum etoposide for small cell, this is what happens. You have a modest but significant improvement in survival. We had some slightly different results with PD-1. This was Keynote 604, which looked at pembrolizumab, PD-1 inhibitor, a very similar design, but unfortunately this study did not meet its primary endpoint of improving survival. We said a hazard ratio of 0.80. Now this was largely felt to be due to statistical design, famously missing significance by one patient. But when we look at the curves, we do see that these curves cross, whereas the other curves did not. We see that the curves look overall a bit less impressive. Regardless, this did not meet its primary endpoint, so pembrolizumab not approved in the first line space. We also saw a phase 2 study by Tiziana Leal looking at nivolumab, platinum etoposide alone versus with nivolumab. This study was positive, meeting its endpoint for PFS and OS, but a small randomized phase 2 with 80 patients in each arm was not enough to change practice. Nivolumab not approved in this setting either. But when we look at these 4 major randomized studies together, we can see that the trend is clear. When we add immunotherapy, we are providing a benefit to a subpopulation of patients with small cell lung cancer. Our standards are atezolizumab and durvalumab as our approved options, signals seen with other agents, but no clinical impact for us yet. So what are the next steps? Because clearly there's significant room for improvement. Can we further refine delivery? Many people point out to me that when we look at the Kaplan-Meier curves, they don't split till about 6 months. And so is maintenance therapy enough? Can we wait until finishing that initial treatment? And it's a relevant question because patients often present quite ill. They want to start early. But Checkmate 451 asked this question. These data recently published by Dr. Taufika Wanakoko looked at Checkmate 451, which were patients who completed chemotherapy, did not progress, and were immediately randomized to Nivo, Nivo-Ipi, or placebo. And what we saw was no impact. These are survival curves on the left for Nivo-Ipi versus placebo, no difference at hazard ratio really at 1. And for Nivo versus placebo, again, no difference here. So using immunotherapy in the maintenance setting in an unselected population was not effective. Another way to ask the question, is maintenance therapy necessary? Can we just give the induction? Do we need to continue what can be an expensive drug afterwards? And that was addressed by Dr. Martin Reck at World Lung Conference earlier this year. And we saw that if you look at outcomes from the time of maintenance, continuing the Tezo does improve survival here with a hazard ratio of 0.59. So maintenance is not enough, but it is necessary. We do have to stick with the data, concurrent and maintenance immunotherapy, really to get the best optimal outcomes. Can we wait until later? As I mentioned, sometimes patients present in distress. They are hospitalized. At many institutions, including my own, I cannot give immunotherapy if someone is in the hospital or inpatient due to billing procedures and regulations. So can we save immunotherapy for later use? Well, this was also looked at. We do know that immunotherapy is active in previously treated settings. Checkmate 032 looked at heavily pretreated small cell lung cancer. Many investigators on this call, what we saw was the median PFS was quite poor. Really that first scan, most people are progressing, but the long-term survival rates were impressive. There were a significant number of patients with heavily pretreated small cell that were alive 2 years later that we wouldn't otherwise expect. And so there was clearly something there, leading to the second line study of nivolumab versus topotecan or amrubicin, what we would consider to be a pretty low bar, but nivolumab was not better. If we look at survival here on the right, we can see that the curves cross the hazard ratio right around 1. Nivolumab was not better in terms of survival versus topotecan. If we look on the left, the progression-free, that very steep drop is the nivolumab arm. And so you can see a very scary drop. PFS actually significantly worse with nivolumab than with chemotherapy, hazard ratio of 1.4, so the wrong side of 1. No improvement versus topotecan in the second line setting. Very disappointing. And these had impacts. As you know, nivolumab and pembrolizumab were both approved as third line options based on Checkmate 032 and Keynote 028 and Keynote 158. These received accelerated approval by the FDA based on limited other outcomes, an unmet need, and the potential for durable response. But if we look at nivolumab, because that second line study was negative, because the maintenance study was negative, the FDA approval was withdrawn in January 2021. It's no longer approved. And the same with pembrolizumab. Even though Keynote 604 was close to being significant, it was a negative study. With a negative confirmatory study, the accelerated approval was also withdrawn. And so the only approval for immunotherapy in small cell is in the first line setting with atezo or durvalumab given concurrently with chemotherapy. What can we learn from those existing data sets? Specifically, who are the patients that are long-term survivors? Well, we've looked at PD-L1 expression and whether it was part of Empower 133 or Caspian or TMB, based on tissue TMB and Caspian or blood TMB and Empower 133, none of these were helpful. These are not good tools at predicting who are those long-term survivors. We saw benefit from immunotherapy across PD-L1 strata and across TMB cutoffs. Those are not useful in selecting patients. We put a lot of stock into specific subsets of small cell based on expression of certain transcription regulators. This seminal work done by Drs. Charlie Rudin, Lauren Byers, Carl Gage, Aparna Sen, splitting small cell into the expression of certain transcription regulators like ASCL1, NeuroD1, PAL2F3, YAP1, more recently an inflamed tumor subset. What we saw earlier this year at ESMO was that these were not useful in selecting patients either. The small cell inflamed subtype did seem to be enriched for long-term survivors with atezolizumab, so getting disproportionate more benefit from the immunotherapy. However, we saw benefit in all of the subgroups. And so use of these subtypes to choose who's receiving immunotherapy is not a valid strategy. It is an important starting point because we do want to appreciate the differences between these subsets in small cell lung cancer, and hopefully we'll fuel research into that field. But right now we cannot use those subtypes to pick who receives immunotherapy. So what we do in the meantime is build on that chemoimmunotherapy backbone to incorporate additional active treatments and to try to avoid things that have overlapping toxicity. Trilaciclib is a drug approved in the US in February this year as a supportive medicine to reduce myelosuppression. I don't really use it in this setting. I don't find that neutropenic fever is a big issue with hydrometopaside, but perhaps this would promote long-term T-cell memory by preserving some of those lymphocytes. We don't know the answer to that yet. Are there other strategies? A famous one is consolidated thoracic radiation, still very much used in Europe. We know the CREST trial did not meet its primary endpoint, but it did meet a secondary endpoint of 2-year survival rate, as the figure on the right illustrates, commonly used when we still have residual disease in the chest, but a good response elsewhere. So is there a role in immunotherapy? Empower 133 and Caspian did not include thoracic radiation, but not because there wasn't value in that. It was really to eliminate the heterogeneity until we knew that strategy worked. Now that we know that, and we know, as Louise just mentioned, there is synergy with radiation, can we use consolidated radiation in extensive stage small cell with chemo IO? I think this study will be positive. It's ongoing now. This is NRG LU007, looking at immunotherapy with Empower 133, chemoatezo versus chemoatezo with consolidated thoracic radiation. And we'll see if that does impact long-term survival. I believe that it will. This being led by Dr. Quinn Wynn at MD Anderson. Another field is limited stage small cell, where we know that some patients will be cured and have a chance for long-term survival, but overall the outcomes are still quite poor, and most patients relapse. NRG LU005 is looking at atezolizumab, given concurrently with chemoradiation and maintenance. Adriatic is looking at durvalumab or durvatremi after chemoradiation, and we'll see if adding immunotherapy to limited stage chemoradiation improves outcomes. We have newer agents like lurbinectedin, a marine-derived transcription inhibitor with impressive activity in sensitive, response rate 45%, and resistant, response rate 22%, where we really don't have other active drugs. However, we do know that even though the drug has received FDA accelerated approval, the confirmatory study, the study that was meant to serve as confirmatory trial, was negative for survival. So we'll see what happens to this drug and what future studies can confirm its efficacy. It is an active drug. We just need to find the best way to use that. There are other molecules such as TIGIT, which has shown promise in non-small cell and is being studied in small cell in the Skyscraper 2 frontline trial. And we also have newer drugs like AMG 757, a bispecific T-cell engager trying to leverage selective expression of DLL3. This is an important one to watch. We have seen activity with responses, rates about 20%, but there is some cytokine release, so we'll have to see how that evolves over time. Our standard of care for small cell lung cancer is chemoimmunotherapy. We're looking for a biomarker, but it really is used in an all-comer approach. Empower 133 with atezolizumab, Caspian with durvalumab. Our current trials are going bigger, adding empiric agents like radiation, anti-TIGIT, but our goal years from now is to get smaller, to really identify specific subsets that we can treat differently. Very challenging, but that is what we're working towards. So with that, I'll stop here and turn things back over to Lucio. Thank you very much.
Thank you, Dr. Liu. It has been a very, very nice presentation, very clear, with a very good outlook on the future. And I thank you for your presentation. And I would like to invite now Paul Bass from Amsterdam to address us the current treatment and future option in mesothelioma.
Yeah, Lucio, thank you very much for the kind invitation. It's a great pleasure to give a presentation, the last one in this CIOT meeting. And I'm going to talk about new developments in mesothelioma. Let's see if I can proceed. Oh, these are my disclosures. So the pleural mesothelioma is something in the Western world what we think is going down in incidence. However, there's still a lot of asbestos being produced, mined, and this is all sent to the developing world, and especially in India, where you see in the bottom right, you see how they how they work with it. And this is something that is going to stay around for a long time. Protection measures are not very often taken there. So we have to look at the best possible way of treating. Now, just for the people who are not very familiar with mesothelioma, it's of course located most oftenly on one side of the chest. It's in the pleura, and it can lead to a shrinking hemithorax with shortness of breath, coughing, and also pain. You can see that the ribs will be more getting together, and this will also lead to problems with breathing. If we look at the 2021 ESMO guidelines, and this is still under review, it is under review by the ESMO. We have decided on the guidelines that patients in a good performance status can be treated with the platinum and pemetrexed when they were given the vitamins, 4 to 6 courses, because sometimes you have a slow responding tumor, and then 6 cycles are recommended. In some countries, bevacizumab is added. It's a level 1A evidence, but I will come to that in a moment. And of course, it's the immuno-oncology session, so I will focus on that in a moment. Now, this is what we had in 2003, and for many, many years, this has been the same. If you give cisplatin with pemetrexed, you can expect a median overall survival of about 13 months. But we have improved that in quite some time. Now, the French started the so-called MAPS study and added bevacizumab to the standard of care. And from these 2 curves, you can see on the left that the progression-free survival was improved and also the overall survival with 2.7 months. Of course, bevacizumab is an antibody for VEGF, but there was a problem with this drug. We also tried another combination, and with platinum gemcitabine, unfortunately, there was no benefit of the drug. With an hazard ratio of 0.77, it was only registered in France and reimbursed. In many other countries, bevacizumab was not a valuable option. Now, if we switch to immuno-oncology, why would it work? Well, of course, we will have to look at PD-L1, and in 40 to 60% of the cases, there is an expression in the tumors. There is also in this very small study PD-L1 with less than 5%, it's 16%, or if you have a higher one, 63% of overall response rate. But this has not been validated in other studies. So we're still having a discussion, should we use this as a marker? Of course, the other one is the mutational load. It is in the middle of this, this graph of the somatic mutation frequency just around multiple myeloma. So one could not really expect to have many neoantigens from the mutations here. And coming to the last, which might be much more of interest, is bromotripsis. That is something that has been identified by Aaron Mansfield, that if you have divisions of the cells, the normal chromosomes can have some shattering, and large chunks of the chromosome will be rearranged, and also some lost pieces will be in the cell. And these might function as neoantigens. So this is work in progress, and we hope to see more publications on it very soon. Now I've put here a time bar, what has happened in mesothelioma, and in the yellow one, you can see the single agent treatments that have initiated from 2015. The green are the combination treatments, mostly CTL4 and the PD-L1, and the blue ones are the combinations with chemotherapy. So this is a bit the sequence that we have seen in lung cancer. So we started in 2015 with some studies, and in 2017 more, the combinations were tested. If we look at the second line treatment where we have started, I put here the 2017 NCCN update because already at that time, subsequent therapies were recommended, not only vinorelbine or gemcitabine, but also nivolumab plus or minus ipilimumab or pembrolizumab, while the data were very sparse there. This has changed enormously. Now, in this overview, I have selected the trials, and the bold ones are the randomized ones, and the red ones have not shown any activity. So I will tell you a little bit more on the determined study, the PROMISE MESO, and there are many other drugs that have been tested. Now there's one in the bottom that should not be in bold, that is pembrolizumab with lenvatinib, and we have already heard in non-small cell lung cancer that this is a pretty powerful combination, and we started in our institution a second line study after standard chemotherapy, have entered now 21 patients in about 4 months, so it's very high demand, and we do indeed see some responses. So the combination of an anti-angiogenic drug and IO is promising even in mesothelioma. Now coming to the tremelimumab study versus placebo in second, third line, the determined study was a pretty big study with a randomization 2-to-1 of the CTL4 inhibitor versus placebo. You can see on the curves that they are almost superimposable. And the most thing we observed was diarrhea. So this was not really a pleasant study to have your patients entered in. And it was, of course, depressing. Now, if we look at nivolumab in the second line as a single arm, single agent study, it was in the MERIT study in Japan, which showed apart from the expression of PD-L1, that you had 30% objective response and a disease control of 68%. And this was already in Japan a reason to allow this drug to be registered for second line therapy. There is also a second line or third line study which addresses the question if nivolumab is doing anything better than placebo. Now, Dean Fennell in the UK, and I think this is the only country where you can really do such a study to randomize to placebo, has performed this study and has been reported. And although it is by the investigator, the PFS analysis, there is a benefit of nivolumab over placebo. And also the proportion of patients alive is really in the benefit or for the nivolumab. So we have now identified that doing something with an IO drug is better than doing nothing. But how does this hold for other types of chemotherapy? And this was the AIOT study, the PROMISE MESO study, also guided by Sanjay Popat, where pembrolizumab was given after recurrence of the disease every 3 weeks versus institutional choice. And that could be gemcitabine or vinorelbine, oral or intravenous. And there was a crossover possibility. So this will imply that you will have some problems with your OS analysis. But primary endpoint was progression-free survival by a blinded independent central review committee. And here you see the data. Although the overall response rate was 3 times higher, which was very nice for the patients, the primary endpoint was really negative. When I heard the study, I felt it was jaw-dropping. I never expected that there would not be any benefits in patients compared to single-agent chemotherapy. So this is a drawback. At that time, in my institution, we started with nivolumab and ipilimumab in a single-arm translational research study where we took biopsies before the start of treatment and after 6 weeks to see what is happening in the tumor itself. Now, because of time restrictions, I will only give you some data. The disease control rate was 68% with the partial response rate of 29%. And the toxicity in the table on the right side was really very manageable because we used 3 milligrams per kilogram of nivolumab and 1 milligram per kilogram of ipilimumab. And that is a different way than, for instance, in melanoma it is done. Now, we were not the only ones that had this approach. This was also done by the French, the MAPS-2 study. And they had 2 arms, which they ran simultaneously, but the study was not powered to really compare the 2. So it was nivolumab or nivolumab plus ipilimumab, just the way I described when we had our study. However, you can always put the data together. And here you see on the blue, the nivolumab plus ipilimumab progression-free survival on the left, and nivolumab is the red curve. So there is an advantage of 1.6 months, but this is also for the overall survival, an advantage of 4 months for the combination. And with these promising data, it was the reason to start with another study. And this has been published in the Lancet at the end of January this year, where in first line now, nivolumab plus ipilimumab was compared to chemotherapy in a worldwide study. Here is the graph. This shows how the patients were treated. Randomization 1-to-1. They have no prior systemic therapy, were in good performance, and the chemotherapy could be given for 6 cycles. Patients were allowed to have retreatment with immunotherapy, but not with ipi-nivo. They could have all kind of other therapies. The treatment was given until disease progression or 2 years of follow-up. And the primary endpoint is overall survival. Now, if we look to the primary endpoint, it's clearly a positive study. We had for the nivo plus ipi 18.1 months median overall survival compared to 14.1 months of the chemotherapy. And at 2 years, something we'd never seen before, we had 41% of patients alive, with still a lot of patients who were censored compared to 27% for the chemotherapy. Of the patients who had chemotherapy, there was about 20% of patients who received single-agent immunotherapy. The study was mature with 29.7 months follow-up, and we also looked at subgroups, but the study was not powered to do a full formal statistical analysis. And here you see something very interesting happening. The median overall survival in the epithelioid group was 18.7 months. For the non-epithelioid ones was 18.1 months. And if you look and compare them for the chemotherapy, chemotherapy does it much better in the epithelioid with 16.5 months versus 8 months in the sarcomatoid or the mixed group. And this is something that is expected. The non-epithelioid always do very bad with chemotherapy. So there is a great benefit in the non-epithelioid group. And there is, well, I cannot say non-statistical because the statistics are only given here by the confidence interval. It just crosses the unity. So if you look at PD-L1 expression here, if you had no expression of PD-L1, it didn't matter if you had nivolumab, epi, or compare it to chemotherapy. But if there was PD-L1 expression, there was indeed a benefit observed with the Immuno arm. There were almost the same number of responses in both arms, but there were 2 complete responders in the ipi-nivo arm compared to none in the chemotherapy arm. But if you had a response, it also implied that the response was much more lasting. And whether this is due to the maintenance setting that we have, that's a good possibility, but we have not identified that yet. Looking at the safety profile, of course, there was more grade 3-4 toxicity in the experimental arm compared to the chemotherapy arm. But one can expect that if you give a treatment for 18 weeks or 2 years, that you will run into more toxicity. Looking at selected trials in the first line now, we have had the Checkmate 743. And there's also now activity in the ETOP with the BEAT-MESO trial, where bevacizumab and atezolizumab are added with the chemotherapy, and then the atezolizumab is not in the control arm. And we have the durvalumab with chemotherapy, and these are 2 studies, the DREAMER and the PRE505. So look at these 2 studies, that is durvalumab plus cisplatin pemetrexed up to 6 cycles, and then durvalumab is given for up to 1 year. Now the target in these phase 2 studies was 55 patients, and the survival curves and the progression-free survival curves are very interesting to see that indeed you will have with the chemotherapy probably a boost in your response to the immuno, what we also have observed in non-small cell lung cancer. And this is in the PRE, the 0505 study, which also shows a very interesting 44% of 2-year survival. But this is a small number of patients, of course, and it is single arm. Now, if I summarize my talk, we have now identified that nivolumab plus ipilimumab in the first line is a positive study. You can say it is for all histologies, although for the epithelioid type, there can be some discussion. Durvalumab plus chemotherapy is now being tested, just like the BEAT-MESO trial in first line, to see what is happening when we combine it with chemotherapy. And I already informed you that nivolumab had already been approved for second-line therapy, and that nivolumab in second and third line compared to best supportive care is promising. And with this, I would like to thank you. We had a long session today, so I will shut up at the moment. Thank you.
Thank you very much, Paul. Now we can open the discussion, and we don't have any question from the floor. I have a small question for Stephen. Don't you think on the basis of the utility of immunotherapy in extensive disease, and on the basis of the results of the Pacific, that has a model that is very similar to limited stage, that we can move immunotherapy to the limited stage disease in small cell lung cancer?
I think those studies would be positive. I agree completely with you.
Yeah.
I mean, we have 2 studies ongoing now. I think it comes down to, should we give it with chemoradiation, as in the NRG study, or should we give it after chemoradiation? I do think that both strategies are probably going to provide benefit. We'll see if there are differences in the safety signal, and also if the giving it concurrently allows us to extend that to more people. But I agree. I think there is a role for radiation. I think that we'll build on what we saw in Pacific, and I will bet that both of those studies will be positive.
Thank you very much. Paul,
excuse me, Lucio.
Yep.
I have a question for Stephen. Many thanks, Stephen, for your coming also this year, and many thanks for your friendship to AIOT. My question after your presentation and observing the similar curves of Empower 133 and Caspian, is the question is if it's possible choose or to think to choose the combination basing on some patients' characteristics, or the studies are similar and the problem is also a marketing problem?
Yeah, so it's a very good question. Is there a difference between these 2 drugs? And I tend to agree more with the latter part of that statement, but I think they're very similar. And while they were studied slightly differently, I think the results are much more similar than different. I think that if you're choosing one over the other, it's primarily for non-clinical reasons. If there's a difference in cost locally, if there's a difference in regulations or approvals or formularies, I think that would push you towards one over the other. Both drugs in the maintenance setting can be given every 4 weeks. Both have similar toxicity and efficacy profiles. So to me, they are very similar, and it usually comes down to what you're more comfortable with. Atezolizumab was approved first. It's a regimen that I'm a little more comfortable with, and so that's what I use in my practice. I'm very happy with it, but there's absolutely nothing wrong with using durvalumab either. That's a very good approach too.
In our clinical practice for extended disease, we are some difficult to use initially atezo and chemo, because small cell lung cancer usually have a presentation, a central presentation in the thorax. There are the pre-mets. The patients use oxygen, corticosteroids, usually can present respiratory insufficiency. So all argument to reduce the combination ab initio with chemo and atezo, and some oncologists, they prefer to treat 1, 2, 3 cycles with only with chemo, and they add atezolizumab. But this is very contrasting with the results coming from the maintenance negative results. So the problem is combine ab initio.
Yeah, I agree that it is challenging. And when I saw the Checkmate 451 maintenance results, I think you and I probably had the same reaction. I was very surprised. I thought that would be a positive trial, and it was a very negative study. So I think what we learn is that small cell lung cancer is something where it's a very humbling disease, where we can't really try to outsmart it or figure it out. We have to stick with what we know works. I think that in my own institution, I have trouble giving atezolizumab with cycle 1 if they are hospitalized, and that's more due to practical restraints. If that's the case, I just jump in with cycle 2 as an outpatient. But if someone is coming in and they're otherwise pretty well enough to receive chemotherapy, I don't feel like the atezolizumab significantly increases toxicity. And so I still feel comfortable with that approach. I certainly would not wait until maintenance or wait until relapse. I would try to integrate it as early as we could. In my own practice, sometimes that is with cycle 2, but I usually try to fold it in early, because maybe there is synergy, or maybe patients are just getting benefit from that immunotherapy early on. And if you're waiting, they may fall off the map and never get a chance to get that benefit.
I asked Stephen, small cell, fast growing, high mutational burden. But if you look in the biopsies, they are quite often immune deserts like. So I was wondering, how could you approach that issue? Should you kill a part of the tumor, give some stereotactic radiation, or is there another way to look at it? And why does the CTLA-4 do so bad? Because you would expect that would also manage the problem for a part.
Right. I mean, there's a big piece we're missing, Paul. I think you hit it right in the head. There's a huge piece we're missing because CTLA-4 doesn't really seem to add anything except toxicity. And that microenvironment is much colder than we'd expect. I would say, small cell lung cancer probably has the most immune suppressive microenvironment of all solid tumors. We don't totally understand why. And until we can neutralize that better, we're really going to be making incremental benefits. I'd really like to focus more on the environment. The challenge is the biopsies that we get for studies on these trials are small tumor biopsies with enough tumor cells to see that it's a small round blue cell tumor, that's a small cell cancer, but not enough to really get a core that's going to capture that microenvironment, and certainly not enough to do the types of analyses that we really want on the environment. So that's a big missing piece. And going forward, I think we need to challenge that paradigm where we've always told each other, we can't get large biopsies for small cell. We just have to do with what we have. I think we need to push back on that because I'll bet we were saying the same thing about EGFR and non-small cell decades ago. And now it's routine every biopsy. I think we need more biopsy studies purely for research because we're very much in the discovery phase for small cell. We know so little about why it's behaving the way it does.
So what do you think of the AMG 757?
Yeah, I think it's a compelling study. I'm impressed by the durability, but when we look at response rate, when we look at PFS, duration of response, I think we also know that we see those a lot, and we need to really see if this is going to translate. One concern I have for 757, and it's still early, it's still in escalation, so the data are still at a very early phase. We usually don't even see data this early, but I'm a little worried about the cytokine release syndrome. There are other compounds in development with cytokine release where it can be a fatal event if not managed properly. And while these were all grade 1 and had no major consequence, I think only one was grade 3. These are at very trained select centers on a rigid protocol. If something like this is implemented across the community, across the world, I suspect we're going to run into more problems with something like cytokine release. And so I think we really need to understand it and try to prevent it more if we can. And hopefully we're looking into that in those trials. That's a toxicity that I think when we scale it up, it may turn out to be much more toxic, almost reminiscent of what we saw with Rova-T, where the toxicity early on was sort of manageable and we want to go forward. And then in larger studies, far too toxic for limited efficacy. I hope we don't see the same thing with 757.
And in addition, we've seen some neurological toxicity of which is very worrisome for patients, losing control in the night over their sphincters, etc. It's also something to worry if we're going to expand that.
Yeah, it's still in the very early stages. We're gonna have to watch these pretty closely. We get excited when we see any signal just because we're so desperate for anything, but it's far too early. Yeah, agreed.
Paul, about the 743 checkmate study for pleural mesothelioma, what is your idea about the EMA approval? Is possible to approve a positive trial, but positive exclusively for a third of patients expressing a sarcomatoid subtype? Yeah,
so that's an excellent question, of course. So the EMA has approved it, just like the FDA. And when I looked the first time at the data, I was also, you know that a part of the data of the primary endpoint is carried by the great advantage of the non-epithelioid type. But however, if you look at these subgroups, and even if the company tells you, well, we did not have enough patients randomized for it, and we did not have the statistical power, I still feel that it's very good as a physician to have your patients to offer him or her something from two different types of treatment. And I've given, of course, a lot of chemotherapy over the years. And I think at this moment, one would probably go for an LB9 approach, 2 courses of chemotherapy and then the immunotherapy. I think then we would have probably the best of 2 worlds. But of course, we have to see now for the different countries where how it will be received.
But a very short question. Do you see any reason why the combination Ipi-Nivo should be better in sarcomatoid tumor versus epithelioid? There is some biological explanation?
Yeah, well, the only explanation I would like to give is it's a completely different disease.
Okay.
I see it as a completely different disease. It doesn't fit if you put it all together. And what I feel, what is positive in the epithelioid, one always forgets that there are at least 6 subtypes of mesothelioma. And if you happen to have a papillary one, then it is completely different than a round cell type. And of course, we see that the hazard ratio is crossing the unity, but many of these patients also had in the control arm immunotherapy. So I think it's still of benefit for the patient. And especially that the physician can discuss with the patient, which are we going to give first? And yeah, that's the current situation.
Thank you very much.
Can I ask a question, Paul? Maybe a simple question, but maybe controversial. For mesothelioma, maybe especially sarcomatoid, is there a role for surgery today?
Oh, you're asking a European one. No, never. Only a diagnostic track.
Yeah.
No, I've seen all the data and all the changes from David Sugar Baker from Boston, and I've even sent patients to him. But to be honest, epithelioid, okay, that is a possibility, but everything beyond that, I think you're more harming the patient than doing
well.
I
agree, yes.
And Stephen, do you operate? You send them for operation?
I send everyone for a consultation, but I don't push for surgery unless there's very minimal disease. There are some cases where it's pretty minimal epithelioid.
Oh, yeah.
Sarcomatoid, I would not.
Yeah, I agree. Well, I think that it has been a very, very interesting session. I want to thank the speakers for their update and wonderful presentations. And now I think that I can close the session and give the microphone to Filippo to close the meeting and to draw the conclusions.
Thank you, Lucio, for your aid to be the chair for 2 sessions. Is my role of president of the conference to close this conference. Is the moment of the thanks. The first thanks are for all the speakers, to the faculty, a faculty composed by friends, and I am very happy for this friendship. I think always that the soul of this conference is represented by the discussion among the friends speakers, and it's clear that this virtual representation represent a limitation for this discussion, but I hope that next year we will be in presence, and you are all invited to be in Milan for the next conference in presence. My thanks to the pharma for their unconditional contribution to this conference. My thanks to Studio Visio for the technical organization. Consider that we manage all the faculty from 3 different continents without any problems. So I am very satisfied for this wonderful technical organization. The most important thanks to Rossella Spinetti, that is the soul of the AIOT, because they managed all the requests of the speakers. Final thanks to the friends, colleagues that were connected in these 2 days with this conference, and I appreciate their participation. We arrived to 100 person connected. I think that in this time is an important goal. So it's time to say goodbye to the next year. In Italian, arrivederci to Milan the next year.
Ciao.
Arrivederci, ciao.